enough time to hang with him and has been enough to impact my life. So imagine if I hang closer. So let's see what fascinating things we find.
Yeah, well, I remember you sitting in the front row at ICMO in Kansas City with lots of good questions.
Oh my God, I was into it because, I have this can and I didn't, honestly, I think it's one of the instruments that I don't use as I should be. And my thinking to use it is being different. But then I think the way that you do it is fantastic. I think that's the first assessment that we're supposed to do.
I use that instrument more than I use my BioPack or my K7.
Yeah, I mean, it makes sense. Honestly, technically, is we reduce the amount of instrumentation, like EMGs, like it's a time where we do it. But my thinking is more about mandibular trajectories, and I know if the trajectory is clean, the muscles need to engage properly, and it's no exception. So I know that I have my temporaries fighting more than my masseter is fighting more than my temporaries. So then, in some point, yes, I record, but not like before. Before I was on a sleep of EMJs every time. And honestly, over time, you realize that you were supposed to expect the changes, that you know what is going to happen.
All
And
right,
then
let's not talk everything now. We're going to have this discussion on a live.
I'm
Please.
sorry, 5 minutes.
We might go over an hour.
Yeah, he's gonna talk about it, and then he's gonna think, well, we already talked about it.
Yeah, no.
Okay.
I'm gonna let you guys. We'll go wherever you want to go, but I'll tell you, I'm probably gonna have a different take on a lot of these things, probably than maybe the majority of your other presenters, because I think we all focus around other things and measure other things. And the one thing I liked about the questions that you sent me was, hey, what do you measure before and after?
Yeah, what you control.
And that is a very long list.
Yeah, but the point also, remember, because this is also a question that we will come, that because we don't want to make the physician instrumental dependence. So I will ask you, how will you do your protocol if you're in a desert and you don't have instrument? If you're capable to do your workflow, your thinking process can be reproduced without instrumentation. And I bet yes, because I think with a piece of articulator paper, like Francesca, you just need to be in the desert with an iPhone and with a chew gum. Maybe you need to be with an articulator paper, you digital dentistry, and then
at that point we're going to guess like all the traditional dentists.
Yes, but I can tell you your expertise. Like I can tell you this much. Like I present my case since I do the lab work in a way that I know that I'm gonna have less interferences because I know where I find them normally in the way I plan case.
You do that, but what we're talking about is occlusion for the masses and for everybody who doesn't know, like, everything that you and I know, right? Yeah. And so not every dentist is doing all of their cases, their lab work.
So then we need to figure it out how to engage the audience with the same question and say, okay, we're gonna lose precision and it's nothing that can give you the timing of the disocclusion. But in my mind, based on my experience, because I learned with instrumentation, is I pretty much know where I'm gonna find them just because I've been using instrumentation for too long. Like for me, I reduce the utilization of instrumentation because in EMGs, I know what to expect. So what I'm gonna measure and track it in that way, if I'm only concerned about I have a good fighting sequence and need to be that I'm doing a report case. But if not, I just move with transition, and then when I'm gonna fine tune my case, I go with EMGs, and now I do micro occlusion and all like scan 11 to see my fighting and everything. That's where I really fine tune it. But in the beginning, in my bulk part, I try to be more proactive, let's say, because again, standardization is my mission, and it's something important that you need to see is I'm not concerned about the people that they already know, because I fight that battle many years ago. try to convince neuromuscular doctors to adopt techniques that another neuromuscular doctors do, it's really impossible because it's a huge ego problem. But if you
Yeah.
get somebody a standard and then do teach them, they're gonna be really appreciated. So that's my people now. That's what I'm trying to do. I want to inspire new people to occlusion, and they will get there. You know?
Yeah.
Sorry, one minute.
That's the overwhelming
1 minute.
majority of the docs too.
Yeah. But we can talk about this. It's just that let's try to find a positive connotation. Let's say that the same for me. People say, so you need the jaw tracker that you have, and I say no. But since I'm a teacher, I need to make the findings and I need to demonstrate. I need to make my lectures with this. But then with an iPhone, you're gonna be able to have a decent kinematics movement to kind of make a simple analysis. And technically, I reduced my console to 7 steps, doing basically with no equipment, just the basics. It covers everything, of course. How I build up that experience and that standardization, because I saw hundreds of X-rays and just based in the other mentors. But the idea is, what is the concept? The concept is the timing of
almost
the
there.
10
Yeah.
seconds. 5, 4. I will advise you when we will be online, okay? Don't worry, because
Okay.
it takes like 3 seconds between we
Okay.
start and we are online. Just a second. I will advise you when we will be on. Okay, right now we are online.
Okay, are we ready for this amazing after evening? Good evening, everybody. It's a totally pleasure to come back here to have you. We're so excited. We have an amazing guest with us that you didn't even believe how many topics we already touched bases in 10 minutes. And then we say, you know, let's keep it for the real thing. Ben Sutter is a fascinating doctor that he's been doing biometrics for many, many years. I met him, he reminded me in 2010 in Vancouver. We were lecturing together. But I'm a big fan from him since I started doing instrumentation and T-scans. He's one of the rock stars utilizing T-scans and optimizing protocols that combine physiological occlusion with instrumentation based in sensors for forces in occlusion. And the reason that we invite him here is that he shared with us this experience with this instrumentation, also what is the concept behind and what is the workers. But let me put Hamid on top, and we're ready for an amazing rest of the night.
Fantastic. Hello, everybody. Again, very happy to have all of you guys join us for this day. I met Ben first in just last year in ECMO meeting, and I was blown away with your lecture there. I found you out after the lecture and kind of cornered you. I'm like, I got to learn this. I thought it was fascinating. So I've been actually looking forward to having you down here joining us for some time, but I think this is the second best, having you on and try to tap in a little bit into that knowledge of yours and share that with our viewers. So I'm really psyched up about this one.
Well, I'm glad to be here, and thank you for the invitation and the opportunity to share. I appreciate it.
Actually, Ben was the first person that say yes. Honestly, you know, this Congress, this meeting was a really crazy rush. And we were dealing with the ideas, but we don't know how, we don't know where we would get. And then all of a sudden I say, you know, I'm going to make my first call. And then I call him and I saw his attitude and I say, if he was enjoying and engaged, let's try and keep going. So thank you for that. You give me the strength to keep making calls. And then we really happy that this happened, honestly. Because I say my wife and everybody that were with me in these days is not emails, is not text messages. We have the luxury of time, and if you want to be effective or do something, you need to put that person in the phone and get the answer that you want right away. And that way you can keep moving. So thank you for saying yes. Okay, so Dr. Ben has been for many, many years utilizing all kind of different instrumentation. We describe as an instrumentation different pieces of equipment that we call biometrics, We have the capability with this instrumentation to measure superficial muscle activity. We have the capability to record sound vibrations into the joints in something that we don't call joint vibration analysis. And we allow us also to visualize the mandibular movement by vectors, because it's not the same jaw trackers that we use in real time with the CBCTs, but we're working in a project to develop something together with the companies in the intercommunication. But Ben has something else in advance. He has one more piece of the equipment that he's combining, and he's utilizing like the car, that they have a special sensors to tell you what is the pressure in your tires or what is the pressure in your brake card. He used a device that many of you knows, but other people don't know about it probably. And it's a sensor that you put between your teeth, and you're allowed to record the forces that occurs between the teeth. But that's not it. This machine has been developed for that purpose, to replace technically the articulator paper, but also has one unique capability, and it measures the timing of the occlusion. So Dr. Ben specialized pretty much in a technique that he developed, that he measured the timing of the occlusion in excursive movements, what relieve or identify the primary nociceptive input in a patient that we don't necessarily, we're going to change the bite, we don't going to change the mandible position. And that can be the initial primary stressor for neurological reactions that in a patient can be interpreted as pain. Correct me if I'm wrong, doctor.
Two corrections. One, I am not the developer of DTR. Robert
Okay.
Kirstein is, and he trained me, I don't know, it's probably 5 or 6 years ago now. And then the T-scan doesn't replace articulating paper. It's used in conjunction with, because no dentist can tell bite force or bite timing from analog occlusal indicators. So those would be the only two corrections.
Beautiful.
Ben, can you give us a quick background on you and you know your dental and professional background?
Sure.
Just a quick.
Well, I think what's even important to include for mindset is, prior to going to dental school, I was 5 years in research, 3 years at UNLV in Las Vegas, 2 years at Columbia in the College of Physicians and Surgeons. And so, you know, it was hammered into me that we have to have equipment, we have to measure things we cannot see when things are happening at the DNA and the protein level. And so jumping over and deciding, hey, I'm going to go to dental school and I want to help people, it wasn't a stretch for me to want to measure a lot of the things that I was doing. So after dental school, my background, postgraduate work was, I did a 1-year hospital-based residency. And then from there, I wanted to learn more about occlusion. And the time for this is really important, because it was 2008 when I bought my first practice. So, you know, I started my business in the worst economic time since the Great Depression. And so I started what that nobody wants to do, right? It's treat pain patients.
Yeah.
And so I wanted to go and learn more about occlusion and TMD. And I started asking some of my peers, well, where would I go to do this? And they said, well, whatever you do, don't go to Las Vegas. Stay out of Las Vegas. And so, being a naturally curious person, I'm like, well, what is it about Las Vegas that's so mysterious? So I went to LVI, and my introduction to neuromuscular dentistry happened there. And these doctors were all talking about EMGs and jaw tracking and listening to joint sounds and trying to quantify all this. And for me, it was really close to home. So I took one course, bought a K7. This is the way that I'm going to practice dentistry. And it seemed to me that you had more to hang your hat on than what I think or what a patient reports, right? It's subjective. So from there, I had to take some time off from CE. I had a family member get sick for about 2 years, and things were pretty dicey, so I wasn't really growing professionally, I don't think. And then started with the Perfect Bite, which was the precursor to True Dentist. So along with my K7, I incorporated a T-scan, but I didn't have EMGs and a T-scan that would talk to each other.
Mm-hmm.
And so I practiced with my K7 and my T-scan as best I could, although I didn't have definitive training with the T-scan, which is very, very, very important because it's not intuitive. I think the bite force portion of it is intuitive, but the timing is not. And then I started seeing some DTR videos. Nick Yanios was posting some videos, and he was doing things that I like, helping patients with headaches and pain and vertigo and all these crazy things that dentists traditionally are not taught. And he was doing it so much faster than I was doing it. And so I kind of thought, well, this guy is either full of it or he has information that I need. And so I called him up and we spoke for a couple of hours. And I said, hey, can you teach me what you know? And he's like, no, you need to learn what I know from Robert Kirstein. You need to learn from the man. That's how I was trained. And so I'm very grateful that that's what his response was. So I had Robert in the office and we spent a day together with, I had to go out and buy EMGs that would hook up to the T-scan so you can see what's happening in real time. And now I own two complete, I own the whole BioPack and the whole K7 and the T-scan. But my day with Robert really opened my eyes. So I'm very objective and I can dump what I don't believe or what I haven't figured out, or start to combine and adapt known paradigms to fit the new information. And I think that's where a lot of us kind of drop off. So, or get frustrated, or like, well, I don't want to, there's no reason for me to take all this CE because Javier, you know, I mean, if I were to ask you, how much money have you spent in CE since you graduated dental school, you would have paid for dental school.
Let's not talk about politics.
Yeah. So that's kind of the background. Did I answer the question? Probably more than you wanted.
Yeah. No, it's interesting to see the evolution of the person and how you got yourself into that, where you are now. So it's important. Sure. So do you have anything, or should we get going to our
let's go to the questions because we're gonna absorb his brain during those questions. That's gonna give us a sequence for the people to get engaged, because I'm ready for my big questions already. So let's create some foundation.
Okay.
All right.
Shoot.
So Ben, our first question is fairly straightforward. What is occlusion to you, and who has influenced you?
Wow. Okay. So what does occlusion mean to me? I think part of the discussion has to be with people splitting hairs over occlusion versus occluding. And for me, occlusion is the static relationship between the top and bottom teeth, but it's also a dynamic relationship between the two. Because if you change the surface morphology of occlusion, even if you don't change VDO or joint position, you will change trajectory, and you will change how the muscles behave. So that's it. It's the static and dynamic relationship of the teeth. And there's a lot of things that come around that are adjunct that are very, very important, like the joints and the nerves and the muscles. People that have been highly influential would be probably every single neuromuscular dentist that I've ever talked to has probably given me spades or advice, but LVI probably would be at the top of the list in the beginning of my evolution, and then incorporating, you know, ICMO, International College of Craniomandibular Orthopedics, and then taking in, let's see, Mark Montgomery gave me my introduction to T-scan, and then even picking it up even more with Robert Kirstein. And I saw you had Bob Walker on here earlier today. He opened my eyes to, leveling, the maxilla before you getting started, and sutures not being fixed, which I wouldn't say I wouldn't say was a revelation, but it certainly helps explain a lot of the things that we see when we're treating pain patients, or when I'm treating pain patients.
Fantastic.
Right.
Let's go to question number 2, Ben. Which
Sure.
factors do you consider prior to stabilization, i.e., example, posture, sleep, airway, things like that?
Well, all of those, and I didn't take the question to mean exactly what you're describing, just because we're kind of addressing that question a little later on. But what factors do I consider prior to stabilization? I'm going to just swap out treatment. In this case, it would be maxillomandibular discrepancy if there's a skeletal issue, or is it purely just an occlusal issue? So a lot of the things that you were, some of the things that you were mentioning as far as, well, airway, and yes, absolutely consider airway. In fact, every patient that comes into the practice fills out an Epworth sleep scale study. So, I mean, not a study, but just an evaluation. So we can kind of get a, do we open that can of worms, or this patient really doesn't have a concern there?
Are you taking CBCTs in the first appointment for general patients?
No, not in the first appointment.
Okay.
Everybody gets a T-scan first appointment.
Okay.
That's the next question, actually. What type of information or diagnostic records do you collect, and why? So you're always starting with a T-scan just to rule out occlusal issues, or document them for that matter.
Yeah, tell us how that first experience with T-scan, or why you consider that as your first step, it will land in another pathways to go deeper or different directions or in an interdisciplinary way. Why that T-scan start giving you, I just want to be able to read your brain and copy it. So why is that way? Because honestly, we far way more complex, and maybe simplicity is excellent. So I want to learn for that.
Well, I think you could put up a CBCT and start going down a rabbit hole with the patient, and then the patient just kind of, glosses over, and you lose them. The nice thing about T-scan is it does give you the documentation that Dr. Nasseri was talking about, whether this is a pain patient, a new patient that just needs, to establish care, to establish treatment, or it's a pre-ortho patient, or is it a cosmetic patient? And so no matter which way the patient discussion goes with the doctor, or what they want out of you, it is a way to document, hey, you had this occlusal problem before you ever came in, and we knew you about it. So, and no other occlusal, there's no other way to get that information, right? So a new patient comes in, you take a full set of x-rays, that covers your decay, your abscesses, perio architecture. You're also gonna do a periodontal probing, but nobody looks at occlusion in a way that can be documented. So at a later 2 years, 2 months, 10 years, you can come back and say, well, this is where you were when you came in, and you're in the exact same place that you were, or hey, Mrs. Jones, something's happened and we need to address it. Because not everybody that comes into your patient, to your practice, is going to need a full workup like we can all do. However, wouldn't it be nice to know if a patient came in with a pre-existing implant, that implant is overloaded? I mean, are you going to do a full CBCT and a K7 or a BioPack workup to figure that out, first of all, you're not going to get that information. So, and the second reason why I like having that part of my new patient intake is that the patient doctor, or the interface, you put that up on a screen and the patient will say, hey, you know what? I feel that. And I've been to 5 dentists who have tried to fix this and none of them have been able to do it. And so right off the bat, you get, with a lot of these patients, you'll get instant credibility, and sometimes the patient directs you down a pathway that you didn't even feel was going to be discussed. And it's quick. You know, what is it? How much time does it take you to do a full workup, Javier? I can do all my occlusal records in less than a minute.
Nothing like that, for sure.
Right.
Now, do you want to give us, before we proceed with more questions, you got to educate us about what you're looking at into that occlusion? Can you go over the concepts before we go deeper? Because maybe when everybody understands what we're talking and what is DTR exactly, maybe they're gonna engage also the public with some questions. Let's go a little bit about that. Let's go a little bit about the science of the process, what you expect, and what is the protocol where you do it.
Okay. So I guess I need you to ask the question again, because if I were, so first of all, a DTR is like a 2-day course to hone in on what the rationale, what the science is, how to do it. And to answer that question, I just want to make sure that I'm hearing the right thing. What, can you just repeat the question?
Don't worry, my Spanglish can be worse sometimes.
I'm doing okay.
No,
You're doing.
it's good. I mean, for a guy from Oregon and understanding me, that's a luxury. So maybe, I mean, you need to trust.
So I guess without getting into, you know, we understand this is a complex subject, and it's true. Javier is right. We don't want it to get kind of lost. But for instance, you know, for me, when I first heard it, it was the first time in ECMO, and I had not even given a thought to that. So can you just briefly explain, as brief as possible, the whole
Sure.
idea behind DTR?
Okay. Well, the tech scan is going to, first of all, DTR stands for disclusion time reduction. And it's a fancy way of saying, it's a horrible name, okay? But it tells you exactly what it is if you understand T-scan data, okay? So when you bite down, you have bite force that's registered all the way across the arch, and it'll tell you, the T-scan will tell you right and left balance as far as how much bite force is being distributed across the arch. It'll tell you if one tooth has a higher percentage of bite force out of the total bite, and it'll tell you timing. So a lot think of timing as the order in which the teeth contact. That is one way to view timing. However, in terms of T-scan and function and parafunction, the length of time those back teeth stay together is what I'm talking about when I'm talking about bite timing. The faster the teeth come together or come apart when you're going into excursive movements, that mechanism does a lot of things for us, right? So, Javier, I have a question for you. Sure. When you are getting your, and it's fair to say that you haven't been trained on T-scan, you're comfortable with your protocol, but do you do chew cycles?
I'm trying to do chew cycles, but with articulator paper, we do with gum. And then I'm trying to figure it out how you can combine both without being that sticky. I'm flipping the sensor. I try with wax, but I'm willing to learn how to do it because I'm really engaged with chewing cycles.
So were you taught the same as I was, that you put the gum on the, like, let's just
On
say the
one
right
side.
side,
Yeah,
and then on the left side you have the
the
white
paper. Yeah.
and then you get rid of all of the interferences, and then you switch them. You have the wax or the gum over here, and you have the paper over here. So how do you
And then
get rid of
in my last, I made the patient to try to make the chew the paper, even that is nothing to chew, because it's impossible to chew and control the forces in the same side. You know,
That's right.
so that's the point. So how you do it? I'm curious.
Yeah, you can't do it. I mean,
Okay.
what you're explaining is probably the best attempt to do it.
Okay.
But the best way to get rid of working and non-working interferences would be to bite on the T-scan sensor, hit record, bite on the sensor, and then have the patient to the right. And then you could mark the right, go to the right, go to the left, and you can correlate which of those marks are important and which ones are not. And that'll give
Okay.
you the working and non-working interferences on the right side. And then you would do the same thing going to the left, and then you would mark your paper, and then you would be able to
Yeah,
see.
but my question will go, because the occlusive trajectories are not the same. So I did a study that I get a patient and I put three different orthotics with three different canine guides positions, for instance, trying to prove this concept that we really need canine guides or not. And my point is, we don't. Their proprioceptive input that the patient can glide to the canine guides as far as they feel it, just because it's in the corner of the mouth. So when I change the canine guides into the splint of the patient by proprioception can follow that as a disocclusion. Dr. Legal for France write a book that I'm really happy to share the article with you. And he described all the events. What's the fact? We have one speaker from France, Milio, that he get trained with Dr. Legal, that is the one that write the articles about. He write about an article that is called Canine Guides, Reality or a Myth, right? And then part of his studies, what he's demonstrating is, yeah, if the patient use the canine guides, the patient with canine guides never will wear off or destroy or have wear facets into the posteriors. So my concern, to get closer to the point, is I'm concerned that when the patient made the occlusive pattern, it's not necessarily the envelope of the chewing cycle. And I don't want to get fooled by a proprioceptive input of the canine creating a disocclusion path that doesn't necessarily reproduce the cycles of the chewing cycle.
No,
That's
but I would say that, is canine guidance necessary? Necessary for what? Are you trying to make a pain patient feel better?
No,
I
but
mean,
the literature, the literature and the regular average definition of function is that you have contact eccentric, the occlusion eccentric, based in canine guides and anterior guides. That's based in the standard protocols of dentistry, right?
correct.
Certainly, when we get training physiological occlusion in any way, we totally understand not. But since the mission that we have with this meeting is engage people that they for different philosophies or they don't have a philosophy, is try to create validation points. I know that canine guides are not important. We don't build it up as a functional part. It's a structural part. To me, canine guides are like two sensors in the corners, like that determine the size of the field that you're gonna play. And
Yes.
somebody, when you touch it, they say, okay, this is the maximum limit. This is your maximum limit, but you need to play here in the center. Don't play in the corner. You're going to spend too much energy. That's what it happens.
That's
People in
exactly.
chewing cycle, they don't make extremely movements. They chew in a
Yeah.
comfort pad, you know?
So let me answer your question, or let me address your statement. You're exactly right. The canines are two goalposts that are extreme border positions.
Mm-hmm.
And when you're using canine guidance, I think there's some misconception in dentistry about what canine guidance really is. No, you're not chewing out there. I don't think anybody's saying that. I'm certainly not advocating that. But if you're using the canine guidance and you're getting rid of the working and non-working interferences, and you're using these canines as guides, as ramps for your extreme border movement, everything in the center is now going to be touching on what? Centric stops.
Mm-hmm.
Yeah. So a lot of people, and do this for anyone listening. If somebody comes into you and they say, "Oh, I've got all this pain on, unilateral pain," ask the patient to put their teeth together, shift to the right, go back, put their teeth together, shift to the left. What you're going to find is these people that have pain, unilateral pain, like 90% of them are locked in. And as soon as you free that up, pain goes away. So it's about freeing up the range of motion and eliminating the compensatory mechanism that keeps the teeth from propriocepting and banging around each other. So
yeah, but we know,
all three of us know that the muscles can only maintain that for so long.
yeah, but here we go in a deeper arena. Now we need to start talking about mandibular trajectories, because
Okay.
the mandibular trajectory of a class 2 patient with supported occlusion into the back with a deep speaker, that chewing pattern, independent if it's inclusive or explosive, intruding or out, is always going to be distalized. Why? Because we all know that the capsule in this patient is more distended. The patient has the capability to function more anterior, but the posterior support of the occlusion is just insufficient. Now, when we talk about occlusion, we're talking about muscles activity and contraction that they're going to execute on a specific rhythm of movement between all the muscles to allow to create the cycling, right? So in a class 2 patient, that contraction to match the food is going to make a primary contraction between masseters and temporaries, and it's going to try to bring that mandible to the most posterior area. And that's why you can see class 2 patient with a lot of wear into the posterior areas, some into the breakage into the front. Now, when we, for instance, we restore a patient like that or change the bite, try to recapture a more physiological position, now we create a new mandibular trajectories. And we expecting that that chewing cycles goes more in the functional pathways. And most people just take chewing cycles into the teeth, but I'm being focused, since I'm seeing the joint function internally through this technology that we use, and more focused in how is the lines inside of the joints in the 3 dimensions when we create the cycle. And what I found is a length for that anteroposterior chewing cycle depends in how far the patient is for the occlusion. Now, what I'm seeing in those cases is many of the movements, even that the literature describe specific pathways, those patients has a chewing cycle that they go in an oblique pattern because they have the functionality to work anteriorly, but they have the deficit of the support into the back. So this patient need to go for long strikes to try to achieve like a combination between that functional spot and that occlusive spot that bring them back. So how do you compensate that in a patient, for instance? How you don't get full? Because my concern is you're doing equilibration. So how you don't? Okay.
No. You can't use that word.
Okay.
At no time did I ever say I ever do equilibrations. I don't.
Okay. We call coronoplasty, emaloplasty. I personally try to adopt more prosthodontic language lately, so I call my thing equilibration, craniocervical equilibration, but I call it equilibration. So I apologize, it wasn't the right term.
Yeah, no. Equilibration defines a very specific procedure where CO is concurrent with CR.
Oh yeah, I don't do that at all.
And there are no hard stops. DTR has very specific predetermined goals, and it is done at MIP or CO, depending on which version of CO, just the definition of CO that you subscribe to. But let's use maximum intracuspation.
Correct.
Now, you spend a lot of time given me a scenario on a class 2 patient. DTR doesn't work on class 2 patients.
Okay.
Okay. So just like anything else, you have to be smarter than your paradigm, right? There are patients that we would do an implant on, but a diabetic who's running a smoker that's a diabetic running, a 300 on their glucometer is not my first choice for an implant. So you can't just put an implant anywhere you want just because for the sake of placing an implant. DTR is the same way, where you could put a piece of plastic in between people's teeth, and you can do it on anyone, for sure. But you still have to make sure that the bite timing and the bite force on whatever you stick in between the teeth is within certain parameters. So, yeah, I don't mean to jump on you there about.
No, but it's good because we were learning. Now, so let me ask you this now that you mentioned. So you say T-scan doesn't work in class 2 patients because okay.
That's not what I said. What I said is you can't do DTR on class 2 patients. T-scan is going to work on everything. The sensor will work on anything. So there's a mat scan where you take off your shoes and you step on the mat and it'll tell you foot power, right? Or sway, or it's the way to measure how brake pads come against, a disc rotor. So anything where two different surfaces are going to touch and you want to know how much force it's taking on or how much time it's taking to do that, T-scan has applications in industrial and dental is just one of them. A lot of people think, oh, it's a dental company. Well, it's not. It's an industrial company that has a dental application. So it doesn't really feel the niche of like a Burkhardt or bioresearch. Dental is just one component of that company.
So let me come back to the class 2 patient. So then you see this patient and then you realize, okay, class 2 patient, the trajectory is not correct. So this mandible eventually needs to go more forward. And then, so that's the point that I want to do. So then you realize that, and then you go for additional information. You say, now I need to get a trajectory. I realize that the mandible is not in the right place. So what am I going to measure it now? Let me just build the occlusion where the structure it has to be, and then I will do that. So the question
on a patient like that, I'm sorry, but on a patient like that, you will go to an orthosis, and then you adjust your orthosis with that DTR.
Yes, that's exactly what would happen. So, and one of the first questions you asked me, what are the things that you consider? If someone is only touching on the left side and there's a 2 millimeter gap on the right side, how are you going to adjust these teeth to get this to stabilize? You wouldn't be able to. There's a structural issue. So you have to fool the neurology and put something in between the teeth that's thinner on this side and thicker on this side. And then you would use the T-scan to balance and get your timing and your anatomy all the way you want it.
Perfect.
But the principles are the same.
Yeah, I think the beautiful idea is because many neuromuscular or physiological dentists, they think they just because measuring superficial muscles activity can replace the utilization of a interocclusal device that can give you that. And to me, I think additional piece, that we have a scan that we can measure like the first tooth contact. That base is driven by muscles, but we don't even know if the position of the tooth is there. That's how we learn at the beginning, the foundation neuromuscular dentistry, and then we realized that was really fluctuating in the result, that you never exactly know where it was coming from. And that's what I took the decision to get involved with this scan, because I say, okay, it's important. We need to have more information, and to think this is when it's really, really valuable.
Right.
Okay.
We're at 22 minutes. We have a lot of questions left.
Okay, keep going.
All right. So this is a quick one. Which instrumentations are you currently using to collect your data?
Okay. So I
What
only
is the
took
question that it shows what you measured during, before, and after the treatment? Because that's gonna be your favorite question. Which one is that one, Hamid? We have one question that it measures what we take
Well, this
before
kind
and
of,
after.
this is all the instruments that he uses. This is the question that he could say, I use these at the beginning and I use these at the end.
Yeah,
Whatever.
because in Ben, I'm really interested because I love him that he's really measuring, and as he's mentioned before, his background in research with comparison. So I'm really curious what can be what he used before and after. Or I know that maybe can be a stance for him, but I think you can combine the answer with whatever you use and just tell us how is the workflow.
Sure. So, well, T-scan, obviously, I've already mentioned that, and the biopack. So I'm looking at joints with JVA. I'm using a cone beam to analyze the joints. Don't always do a follow-up immediately cone beam. First of all, you're not going to see much anyway. But generally on teaching cases, maybe at a 2 to 5 year interval, if the patient's still in the practice, take another cone beam, sure. But before and after, it's always the same. It's mastication, it's T-scan, it's joint vibration analysis, posture, and MAT scan.
Awesome.
Math scan, what is that?
MAT scan
Yeah.
is the same technology of T-scan, but it's basically a floor sensor for you to stand on.
To get the
And
sway of the body.
yes, so when you change this, the foot balance and sway changes. So what you see when you use this is that there are consequences for your dentistry, whether you're adding dentistry, you're subtracting dentistry, or you're idealizing or optimizing the bite, you'll see changes in all of those.
Understood.
Correct.
Ben, do you approach your treatment as an interdisciplinary, as a group with other professionals, or not?
I try to as much as I can. Usually the patients that come to my office are seeking me out for what I'm known for, right? And so if I don't, it's kind of that balancing act of not wanting to commingle too many therapies. Otherwise, do you know that it was what you were doing, or the chiropractor or the physical therapist or the massage therapist that were influencing your symptoms or the patient? I don't have anything wrong with it. I'm certainly an advocate. I think more minds bring greater wisdom when you're doing interdisciplinary work.
So you don't,
And
but you
that's
don't have a
something that,
set protocol as to, for me, I'm just going to give you an example. Pain patients that come in, I get my diagnostic things, then I work with my PT to correct the structural stuff that I see that I would like to be corrected before I take my bite. You don't have any set protocols as that, or do you?
well, no, I do have an evaluation, which is what the Posture Screen Mobile helps me with. If I'm seeing some funky things like this, or there's something obvious in the shoulders or a head tilt, we'll go ahead and do an evaluation with Chiro before we do anything. But no, oddly enough, it's not a part of every single patient's workup or treatment,
right.
because there's so much change that can occur. And I think the benefit to anybody who wants to measure or use, you certainly don't have to go out and own all the toys that I do to impact patients greatly. But if you're not measuring, how do you know? And so I think you opened up Pandora's box a little bit when you start talking about, multidisciplinary approaches. We can't even get most of the dentists to agree that occlusion should be measured.
Yeah, that's true.
You know? So how do you make that leap from, hey, first let's just start with a T-scan and let's take some ownership, or better yet, have the patient own their current condition, and that takes the onus off of us. And then from there, you can branch out and add a lot of these things to your protocol.
That's actually what I was going to ask you. That what is the sequence of your treatment? So you first, all you're doing, you're just obtaining objective data on these patients rather than saying, hey, you know, look like you have this or you look like you have that. You're more about that objectivity and measurement.
Every single, yes, on every single TMD patient, and every patient that comes through my office gets, you know, the T-scan. So when you come to my office and you want a, let's say, a consult, like, is this something that you think is even can help me? Then the question would be, okay, well, let's gather some data and let's see if you present with the things that I correct or I can recognize and share with you. And then let's say that, yeah, there's a timing and a bite force discrepancy. And so you give the patient, hey, you've got 70% of your bite force is on the right. You've got inner ear issues on the right. You've got headaches are only on the right. This really kind of correlates with what I see in my patients. All right, fine. I want to do this. The next time the patient comes in, we're gathering all of our data. That first appointment is 3 hours. The DTR only takes about 20 minutes, but I'm taking a cone beam, I'm taking photographs, I'm doing JVA, we're doing chewing analysis, we're looking at all these different things. We do our treatment, and then I run through that same protocol again, including mastication, right?
Mm-hmm.
And then, and currently we're checking mastication at 1 month and at 3 months. And then once, because we're doing a study, and then once we're done with treatment, a lot of this is dependent on patient compliance. But when they come in, they're like, hey, I feel better. Give them a questionnaire, fill out your symptoms. Don't show them the symptom sheet that they came in with. You compare the two so you can gauge, and then I'll run through it again because I'm presenting, I'm lecturing more, and doctors want to see these cases before and after. And as someone who's an educator, you should be taking pre-scans and post-scans from whatever therapy that you're delivering. Otherwise, how do you know what you did? Because the patient told you they felt better? That's important. That's our goal. But how do you know you didn't improve, 80% of symptomology, but you greatly improved mastication? Patient no longer gets tired when they chew. Muscle synergy is better. Well, if you don't measure, how do you even offer that to the patient? Is, hey, this is all the areas where you improve. That goes a long way with patients.
Correct. Jump in, we have like 15 minutes or so. Next question is, do you consider facial aesthetics for your final treatment?
No, I don't. And I'm going through a bit of a paradigm shift in my practice where I'm going from a doctor who was doing a lot of cosmetics and a fair amount of reconstructions to a guy who's being sought after for one thing. And so I still get people coming in for cosmetics. The reconstructions, not so much, but basically more and more of my practice, general practice, is people that are like, hey, you know what? I can chew really good on the right side, but I can't chew on the left. Do you think that T-scan thing can help me? Let's take a look. So I wouldn't say that it's not important, but I would say for the patient demographic, it's not something that I incorporate or use a lot.
That's fair.
So now, any consideration to establish your vertical dimension I mean, just normally goes associate the question with facial aesthetics because you know that when we do neuromuscular dentistry, we highly criticize because excessive vertical dimensions and unfortunately poor aesthetics many times because the proportions of the teeth. So in reference with that, is any consideration for you during that process? Like, are we really more conscious these days in the way that we take bites because we really want to be more conservative in the fat or vertical dimension? Mostly in a case that is not necessary, like a patient that is not in a full deep bite or something like that. What can be your thinking process in that?
So I only build probably about 3 or 4 orthotics a year. So
Wow.
it's not at the forefront. Most of the patients that come in, I treat at their existing VDO. And even though we're adjusting occlusion, we are not decreasing VDO, which I think is another misnomer, because we never adjust centrics other than to make them from broad contacts down to small pinpoint contacts, right?
Mm-hmm.
So if you're not adjusting centrics, how are you changing VDO? Now, on a case that comes in that this got extensive wear and you see dentin all over the place, then yeah, we have to consider our VDO, and I would probably work it up much in the same manner. In other words, I would take a TENS bite, make sure my trajectory was either they're in a removable or a fixed orthotic. We test out that position. I do in my fixed orthotic, I would essentially do my case finishing to make sure that I can reproduce in porcelain what I've created in plastic, right? But you would be surprised because I've actually got about 200 patients and I'm doing all of my neuromuscular measurements, right? I continue to do that and I'm building a database. And what I'm finding is the CEJ to CEJ and the automatic, hey, this patient needs to come down and forward, I'm not observing that. So someone who has a CEJ to CEJ, 8 to 25 of 11 millimeters, you would say, oh my gosh, this patient is way overclosed. They need to be opened up. We need to do an orthotic. We need to do either braces or full mouth rehab. It's not what I'm observing. It's not what I'm measuring. And so once I get probably about 5 years worth of data, there'll be another paper where here's the range, here's the mode, the median, this is what we found, this is what we did, and none of these patients were opened up. So then the question then comes back, well, how important is occlusion? Well, if you just took that one thing out of everything that I've said, and you said, well, we didn't open the occlusion, we didn't come down and forward on any of these patients, would you change a paradigm? Would you alter it in some way?
Definitely, you impact my thinking process. That's
That's why we have you here. Yeah, absolutely.
Yeah,
We have to try to find the most conservative way and the least traumatic to the patient. And certainly this really gets us thinking about what we should be measuring, what we should incorporate into our thinking and to our sequence of treatment.
That's awesome. I'm happy if the people is follow and excited as I am, how much learning, because sometimes when you see different thinking process, that's what it make you excited, because now that is making my mind, okay, I need to try that. I need to measure that. Can be cool to, so this is my thinking. I think if people is engaged, this is wonderful. Okay.
Well, and Javier, one other thing, because people see me doing things and making videos where I'm treating trigeminal neuralgia with DTR, or I'm treating Meniere's disease with DTR. And if you understand and you know what the pathophysiology of what's accepted as how those disease processes manifest, and you say, well, how he first of all, the patient didn't have trigeminal neuralgia if he adjusted the occlusion and the patient got better. Right. Like, that's the point. So let's back up a little bit and go down the rabbit hole really deep and dark. So if we know that, and this is from the peer-reviewed evidence-based literature, trigeminal neuralgia can appear and reappear in the presence or absence of neurovascular compression around the trigeminal nerve. And that only accounts for 10% of the people that are diagnosed. I haven't diagnosed any of these people with these diagnoses. They're coming to me for a second opinion. Like, hey, I'm just like that person on that video, but I've been diagnosed with Meniere's disease because my hearing changes, I've got tinnitus, I've got vertigo so bad that I have to lay down. Do you think my bite could be related to that? And it's only because at the beginning of my career and my journey, part of the diagnostic process was, well, what's the harm in building a orthotic and just seeing if that helps? Well, okay, you do a couple of those, 5 or 7 of those, and you're like, huh, if I can make the patient better in an orthotic, I certainly should be able to do it by getting the occlusion right. Lo and behold, that is what I observe. So again, the importance of occlusion, and I'm looking up and I see there's like 36 or 38 people watching. I wish that there were 38 or 37 people that were a neurologist or an ear, nose, and throat specialist, and not just dentist, because of that 38, maybe 10% will run out in the next year and say, you know what, I'm going to incorporate this technology, whatever technology, into my practice, and I want to start seeing these patients or seeing if I can help them. So again, that's part of the journey, and why I don't want to give the impression that I'm cavalier. Hey, if you're having, erectile dysfunction, just come to the office and I'll do DTR on you and it'll go away.
You'll have a line. You'll have a line.
Yeah.
If that replace the prostate exam, everybody prefer a TIT scan, I guess.
That's right. We would be very busy.
Ben, let's move on. Thinking about the joints now, and I do realize you're probably not doing any surgical work. Have you heard or have you given any thoughts to the possible introduction of, or do you know any of it, of PRGF or growth factors or IPRF into the joints in order to regenerate and remodel?
2 concerns, 2 points. One, the answer in short is no. And the second concern would be, I would want to be very sure that whatever was the etiology for the wearing of the joint system was taken care of before I would introduce that as a therapy.
Yeah, that has been the consensus, that the traumatic or compressive forces should be resolved before the introduction.
Yes, I would agree with that.
So I think I know the answer to the next question, because you do have that math you said, but the next question is that, do you notice postural changes after treatment, expected, unexpected, positive, negative compensation? But I'm getting the feeling that you do.
I do see that. In fact, in the T-Scan book, there's a whole chapter written by Patrick Javier, who was up in Canada, who talks about the occlusal postural link. And again, it's one of those things where I attended one of his seminars, and he's doing sports orthotics, and you still have to, you take it, you have to get the bite dialed in for those things to be really, really effective. And he's documenting posture changes. And again, it's one of those, if he's doing it with an orthotic or sports guard, I should be able to observe the exact same thing in my DTR patients. And then so you go out and you buy the software and you're like, I'll be damned, I see the exact same thing. So again, that paper's not written either. But Patrick's already written a book chapter.
Yeah, Patrick is amazing. Yeah, good friend. Honestly, this is fascinating. The only problem that I have at the moment is called my wife.
All right.
She doesn't let me buy more toys. So she say, no more toys. I just get a new intraoral scanner that I didn't even open it. So she say, no more toys. She's doing
Until you
patience
finish
to me.
this one. All right, guys. We're at the very last minute, but I think we're going to have to keep going a little bit over this one as the discussion is really interesting. We have a philosophical question for you, Ben, at this point. And that is about, do you think or consider that at any point the field will become more open to this type of holistic and inclusive approach to occlusion, would mean in education and in universities and so on and so forth?
No.
Care to elaborate?
You don't pray enough. I'm praying every day.
Look, I pray a lot. Okay, I am a man of faith, and I make that's not no big secret. However, we have to consider that there is a financial and political
Compromises, influences.
That are saying, so on one hand, you're like, well, the universities can teach whatever they want to teach. And on the other hand, you're like, well, they teach to the ADA accreditation, right? And if the ADA is not even aware or paying attention to the fact that the dentists have about a 13% correct being able to choose the correct bite paper marks, the 13% correct, how would you expect the universities to come out and say, hey, this is worth us, investing some time and energy into? And, probably two parts. One would be what I just said. The second part is what drives the market. It's wider, it's straighter, it's brighter teeth. I want a bright smile. No one ever comes in and says, hey, doc, I want you to check out my joint. I think I got a Piper 4B. And most dentists would just be like, what? I don't know what he's talking about. And so you have to, there's no way to do what we do without having some of the technology, and you have to be worried about function. Like, gentlemen, I'll ask you both. How much did you, when you graduated dental school, how much did you know about mastication?
Zero. Yeah.
I would answer zero. Exactly. Now, let's not talk about dentistry. Let's talk about cardiology. On the one, and I'm going to say both of these doctors, we're going to compare two doctors, are Harvard graduates, and they did their residencies at Yale, top of the line, right? One guy operates his practice with a cardiac enzyme test, stress test, 16-lead EKG, echocardiogram, and fluoroscopy. The other doctor with the exact same background has a stethoscope, and he listens to 14 different cardiac sounds. Where is the gap? Is the gap because we don't want to buy all, and I'm speaking now back to dentistry, do we not want to invest in our patients and our learning and our profession by buying some equipment that would help us with some of this stuff? Or are we just going to do all of our evaluation in occlusion, mounting models, and using wax wafers? So, as dentists, by the way, all of those things that I mentioned for cardiology give the doctor information to improve function. Okay?
Yeah.
I don't know if the stethoscope can give you anything that would improve function. So now let's apply that same analogy to dentistry. Like, how many functions do we have? We only have one. It's chewing. How many dentists are evaluating the stomatognathic system on how it functions? Zero.
Zero.
We're not taught it. And unless you're going to spend some 6 figures of your own money to go out and travel and, you know, take away from your time, from your practice and your family to go and learn all this stuff and then bring it home and apply it, who suffers?
Patients.
The end user, the patients.
Totally agree. Good point. Good
So-
point. That is, this is the beauty of this. Sometimes you don't hear what you want to hear.
Yeah,
Because,
no.
I mean, no, technically, because I'm a dreamer, a believer, I say, fuck, I need to be one day when my door is bigger, that is a better future. And I'm praying for that. I say, I'm doing this because a better future. And I believe maybe in some point, maybe it will happen. Maybe at least some midpoint, you know?
I tell you, the one thing that I think will make it happen is if the patients know
And
the
demand.
limitations of dentistry, and then they start demanding better. Like, oh, okay, I'm in Florida. You know, I hear this crazy guy, you know, Javier, he's got all these toys and he's measuring all these things. And I look at his CV and I'm being my own advocate as a patient. And he's done all this training. And then there's a guy who doesn't have any of that. And so as a patient, you would have to have some, I don't know, some experience
Correct.
that
but
would bring
then-
you to that gauge, right? Where
But
you
we're-
would say, hey, I want this cardiologist over that cardiologist.
Correct. Then we're talking about just market segmentation and really the educational background of that patient, because we just had in the last session, for instance, we were talking about the physiologic, involvement in our bites, and there were doctors saying, well, patients don't care about that. They're just coming for pretty teeth. It's true. It's true to a certain degree. But just like kids, I think she said it very nice. My kids always want to have Nutella every day, but I'm the one that has to tell them, hey, maybe not. Correct? Something that is not as healthy for you. So as part of being being the providers, a big part of our job is education and educating our patients about what we do. And that's always going to be a battle. We have one more question, Ben. And this is kind of a listing of things that we're tabulating. And we're going to talk about the events that happen in the joint. So in a specific, in your view, in your opinion, what are the sequence of events that happen in the joint and on the opening, basically?
Okay, be more specific with your question.
So we meaning,
Specifically
we having,
asking about rotation, translation.
we're talking about
Okay.
paradigms that they say that you can open a bite this millimeter because the mandible is just rotating. The MRI that I've been showing, it shows the translation first. The jaw tracker with the joints will see that we cannot appreciate most rotation. Most likely we see patients that the condyle just propels anteriously. What is your thinking about it?
I think you don't know on any particular patient until you measure. But I think that there are 3 studies out there that says you can't separate rotation from translation. And they've been done a number of different ways. Mapelli did his with like 6 different cameras. And then there were a couple of others, I want to say in the early 2000s, that were used in kinesiographs. And interestingly enough, I think Mapelli found that translation happens first and not rotation.
Correct, of course.
So this is the difference between a biomechanical version or a physiologic version. I
Yeah,
think the
or
biomechanical version got us very far. But once you start to buck the knowledge base and what everybody believes, that takes a long time to come around for everybody to accept that, oh yeah, that's the way it is.
so now, as a part of the same question, just to have a picture, a view, where do you consider that condyle should be sitting into the temporomandibular joint? We're trying to find a description for a joint position because when, for instance, when we talk about central relation, the concept has been changing too much. And then I have this personal experience that in many debates I've been talking about central relation is not a functional position, but then somebody show me an X-ray and say, this is my central relation, this is what I finish the cases. And then technically can be what I finish my cases. It's just a matter of description or the way that they get to those positions. So we want to hear the opinion of the speakers about that, just to compare thinking process.
Okay. So would you say, so let me get a little background first. Would you say the best position or most stable position is the position where the condyle has the most coverage from the disc?
For us, we follow the concept of Roccabato that it says that the condyle is a concave surface and the eminence a concave surface, and we have a biconcave disc. So by the anatomy, we're not supposed to be sitting in the concavity of the eminence, and we always need to be in these sigmoid shapes of the condyle where we will
Okay.
function gliding anteriorly. But again, the definition has been confusion. But at the end, when I see results, I see condyles in a good position to my eyes that people relate that with central relation.
Okay. So I'll tell you, I was at a conference and a group of us went downstairs to have a nice private chat. And there was 4 of us there, and one of them was a very well-known oral surgeon in kind of on the East Coast, and he has kind of a history of, before doing surgery, taking MRIs in 4 different positions. One would be the fully seated position. One would be the MIP, maximum intercuspation position. One would be edge to edge. And then the other one would be fully translated position. And in each one of those positions, what he wanted to see was, where is that disc sitting in that anatomy? And one of the things he wanted to alleviate is people saying, well, if you had just treated the patient to CR, the patient would have gotten better. Or if you had just come down and forward into a neuromuscular position, the patient would have gotten better. And what he found was, when looking at a percentage of how much of the condyle is actually protected by the disc, that MIP, 80 85% of the patients had the greatest amount of coverage over the condyle at MIP and not distalizing. And then there was a small percentage of patients who got better coverage down and forward.
Interesting.
To what we would think of as a neuromuscular position. So I guess maybe I'm thinking of it in different terms, but when I'm doing a VDO change or when I'm doing a DTR, one of the things that I'm looking for is stable and adapted joints. And so certainly you could take an MRI, but my first go-to would be something like joint vibration analysis. And if I do my cone beam and things look, decent, then I would not advocate taking an MRI. So there's my answer.
Yeah, great. Okay, I think the other part of the question in reference with the scheme of the occlusion, you already mentioned that what you guys do in the TR is try to reduce the contact areas and try to define more pointed areas. That's
Yep.
what you, okay. Now, any specific position for those contacts that you choosing?
No, well, I mean, I guess the best way to think about it would be to look at some of the old textbooks on occlusion and the diagrams and what would be the idealized occlusion.
Yeah,
And
but in many of the cases, like you're doing a full rehab, maybe you have chance to have good control. But if you're preserving the actual occlusion of the patient and the patient has some wear and tear into the occlusion, you're gonna make a definition of those contacts. What you would be the point that you would try to look for?
well, I would probably, you know, it's always a fine line of how much, where does the patient become a reconstructive patient, right? And so I would not do what I do if I'm looking at a bunch of dentin, because as you guys know, the dentin wears 6 times faster than the enamel. That's not a stable system. So that would be a
Yeah.
restorative position. I mean, restorative patient. So I would advocate having my my centric stops on the mandible, either on the central fossa or the buccal cusps, and then on the palatal, that would be the palatal cusps or the central fossa.
Right. Okay, perfect. I think we get the most of you in this little hour. We wish we have more time,
Much
and
as we
we
can,
definitely
yeah.
we're gonna make more time for the future. I think this was the entire point to get to see these people with magnificent experiences and huge clinical expertise. And this is gonna realize what we have to do when this get over. We know with continual education we're gonna get inspired. Honestly, I need to learn more. That's what I realize every day.
This
We need
is
to learn more.
this
Well,
is
and
a
I do
very
too.
interesting one.
I would love to come and spend a week with you guys and have you guys share with me everything you know, because by no means do I know it all. I'm learning every day.
We are. That's what is the beauty about here. So we
Fantastic.
finished one more episode. I told you from the beginning, this guy is amazing, and we found many surprises. And the more beauty of this is a natural interviews. We just send some questions that the people have the idea what we're talking about, but of course, these evolve in different ways. You're an amazing talker. Good to talk to you. I don't know if that's a good expression. So a good people to talk with.
Thank you, and
Um,
you.
and this has been amazing. So tomorrow we're gonna have three great other guests invited. So tomorrow we're gonna have in the morning Dr. Wen Chu from Singapore, who is gonna be talking about physiological occlusion, but also the influence of the tongue and the tongue tie, and also the vagus nerve.
Vagus nerve, yeah,
Really
that's a big one.
combination of concepts. Really, Hamid knows more about it, but I think he's really, he's a great speaker to start with. And then the content that he has is really good. So he's going to be at 9 in the morning. Then our speaker for tomorrow afternoon is going to be another great friend. I know him for like 12 years, Dr. Cyril Gaillard for France. We went to Las Vegas together to learn
We
neuromuscular
have a good
dentistry.
representation from France.
Beautiful, and he has a beautiful aesthetic cases. He's one of the doctors that I think were able to combine physiology and also in combination with great aesthetics. But the main thing that I want to learn and take home from Cyril is that he get the way to combine some principles of the Professor John Coy's, and he's taking the bites with transelectrical stimulation, but also in combination with the COIS device. And I think people like that because simplicity. And I think he find a way to balance physiology of involuntary forces and neuromuscular arena in combination
Interesting.
with the COIS analyzer. So I'm really looking forward for that. And then to close the night, So you guys are gonna have nice dreams. We're gonna have the amazing Doctora Mariana Evans. She's originally for
Ooh.
Croatia, and she's going to be talking about mini implants for maxillary expansors and the breakage, a rapid breakage of the maxillary suture that we consider that that was only a treatment that work in kids. So she's going to tell you the timing, the procedure, how she make more predictable placing of the mini implants, and what is the different consideration because they different kind of devices. So that's going to be amazing. That's the way that she controls airway. And of course, we know airway is part of the occlusion. So these going to be the three guests that we have for tomorrow. In my personal part, I want to say thank you to first Hamid to be engaged with this project and we could be able to make this beautiful thing, to Dr. Ben to be with us and share his mind, and all of you guys to pay attention and try to understand this Spanglish and a perfect English for these gentlemen. But I think we have the love and the enthusiasm just to share more ideas. What you have to say, Hamid?
Yeah, no, I just want to say the same thing. Thanks, first of all, to all the viewers and really to all the interviewees. Thank you, Ben, for making the time and so selflessly share with us all your experience and knowledge. That means a lot to us. I appreciate
Well, I
it.
appreciate the opportunity, and thank you, Javier, for reaching out and calling me and asking me.
Thank you, brother. We're gonna talk more. Believe me,
All
I'm
right.
gonna get you in your brain. All right,
Absolutely.
guys.
All right.
Have a wonderful night. It's time now to enjoy your families. It's all about love. Have a wonderful night.
Have a
Thank you.
good evening.